Good evening, friends. Welcome to this exclusive webinar on immunomodulation, which is being kindly and jointly hosted by Poland Healthcare and the Sepsis Forum. I've got immense pleasure to have eminent faculties for today's evening webinar. The plan of the flow of the webinar today, first there will be 3 talks which will be given by 3 eminent faculties, and this will be then followed by a moderation, which I'll be very happy to moderate along with all the eminent faculties who are here. Again, on behalf of all the panelists and all the delegates, I would like to thank Poland Healthcare as well as the Sepsis Forum for the joint association and for arranging this excellent webinar. Without wasting much time, I would like to invite my dear friend and the past president of the Indian Society of Critical Care Medicine, Dr. Rajesh Mishra, who is also the director and honorary consultant at the Saiba Comprehensive Healthcare Critical Care Unit in Ahmedabad. So I request him to speak on the course of acute severe pancreatitis with immunomodulation using Ulinastatin, which is one of the approved drugs in the treatment of pancreatitis. So over to you, Rajesh, to take this talk ahead.
So thank you, Subhal, for the kind introduction and the opportunity. Once again, it's a good opportunity to discuss about this molecule. I'm really thankful to Poland for asking me to deliver on this topic, not very commonly spoken on. So my task is very simple. I have to just prove or say that how Ulinastatin works in acute pancreatitis and what are the data to support that. So for that, first we need to understand what is acute pancreatitis is all about. If we just understand acute pancreatitis, what happened in normal pancreas, that in pancreas.
Rajesh, you need to, your slideshow is not working.
No, my slides are working, sir.
No,
I need to.
slideshow is not working.
Convert it into a slideshow.
I have done, sir, that way.
No, you tried, I know, but
I'll do that again. I'll do that.
Yeah. Even now, it's a standard format.
From below, just put it into a slideshow, Rajesh.
Or even on the top, yeah, you know, sir.
Share.
Go on the top slideshow.
Documents.
No, on the top, the buttons on the top. There is a slideshow top, no? On the top.
1 minute.
No, your slides are not being shared right now.
No, I'm not sharing. I'm just. So this is my slide.
Rajesh, share the slide and just put it into a slideshow.
Or down. Yeah.
It automatically comes in that.
No.
You need to put it into a slideshow.
Yes.
Put the your presentation.
Let me share it first. Let me share.
Share it first.
Yes. What is this?
It's not coming.
Wait, sir. Really broken my rhythm. Why it is not good?
All the options were there when you first shared the presentation.
Desktop. No, this one.
Yeah, now share your presentation first and then. Yeah.
Slideshow. Slide control is there. Slideshow is where?
Below.
Sir, a minute.
Now it's in slide. Leave it. It's fine now.
Yeah, it's okay.
Now it's on slideshow. Okay, go ahead.
Most of the time it comes automatically. Okay, thanks. Sorry for the confusion. So my task is very simple. Hello everyone, to talk about Ulinastatin. Can it change the course of acute pancreatitis? So now first we are going to understand the. Is moving. Slide is moving. Can you see the slide moving?
Have you seen that? It's moving.
Yeah.
Go on, Rajesh.
Yeah. So what happens in acute pancreatitis that if you just see I'll take a marker. Sorry. If you just see in normal condition, the with demand for the demand of pancreatic juice for the digestion of food, there is a conversion of trypsinogen and trypsin, which is highly controlled by cholecystokinin enzyme. There is a normal pressure in pancreatic duct. But if any factor which increase the intraductal pressure, like stone in CBD, a common bile duct, or inflammation due to alcohol consumption, or maybe due to other reason, this stimulates the conversion of trypsinogen to trypsin, and with the effect of increased intraductal pressure, it damages the pancreas due to increased influx of calcium. So this is a basic mechanism which applies in the initiation of damage to pancreas. Now, when pancreatic damage happens at acinar level, there is an increased influx of calcium, which causes pancreatic damage, which further release more trypsin, and which leads to the damage of tissue, leads to autodigestion of the pancreatic tissue. Along with that, these inflammatory markers causes damage to the intestinal gut, endothelium of the blood vessel, and which leads to bacterial translocation and more damage. So there is an ongoing local damage and there is an ongoing systemic inflammation. So when pancreatitis happens, if we do not control this conversion of trypsinogen to trypsin, this causes local damage as well as systemic inflammation and increased inflammatory marker, which leads to the inflammatory as well as cellular response. When cellular response happens, more cells get collected to the local site of damage. They causes more inflammatory damage to system as well as local tissue. So this ongoing process leads to the local pancreatic damage as well as multi-organ dysfunction, in which more is the local damage, more is the systemic damage, and ultimately it causes multi-organ dysfunction, which is kind of non-infective but systemic inflammation and more damage to the tissue. What happens if we try to see in this graph? Initial damage, immune response, then protective response, and then late response. Initially, there will be higher surge of the inflammatory markers, leading to the all necrotic tissue. Then increased phagocytosis. Either this can be controlled, or maybe when cellular system get activated, there can be more ongoing damage to the tissue and systemic damage. Initially, there is a cellular response. Initially, there is a neutrophil activation. Then there is activation of the macrophages. These macrophages, if there is sustained activation due to the secondary response, there is a more activation to the activated macrophage, which causes more damage by the activation of T and helper T cells. So basically, the acute pancreatitis, like what happens in any acute damage or ongoing damage, initially it is a humoral response, later it is cellular response. Humoral response is more of the initially local area than systemic area. And when ongoing damage happens, the cell get activated, they cause more damage to the local tissue as well as systemic tissue. If we try to plot the things in the form of pro and anti-inflammatory response, ideally what we expect, there should be balance of the pro and anti-inflammatory system, so there should be less of the damage. But what happens in systemic inflammatory response syndrome? Initially there is a high cytokine surge and then there is immune suppression. High cytokine surge leads to initial rapid downfall like hypotension, capillary leak, more of the organ dysfunction, and later on cell necrosis and secondary infection kills this patient. This is the process. So initially, when we do treatment in acute pancreatitis, initial phase is monitoring and resuscitation, more of the fluid. And the secondary phase is when there is a secondary infection happens, initially bacterial, later on there can be any type of infection, and to prevent that and to the manage. And that short is all about the pancreatitis management. That's why in initial phase, controlled resuscitation, where we do not give more fluid, more of the rather than monitor fluid and controlling these inflammation. So if I have to explain this molecule really works very well when there is an ongoing cytokine storm. When that means in severe acute pancreatitis, in first 5 to 7 or 10 days, when there is an ongoing pro-inflammatory response out of proportion to immunosuppressive response, at that time, this anti-inflammatory molecule works well. It doesn't give that good result where there is an ongoing immunosuppressive phase. In that phase, it can be even counterproductive. So we have to always remember that immune modulator, immune inflammatory, anti-immune inflammatory drugs works very well when there is an ongoing cytokine storm. It doesn't work in later phase of life. And the purpose is to get it balanced, to make it imbalance of the pro and anti-inflammatory and control the ongoing damage due to this cytokine storm. Now the second phase is about the drug. What is ulinastatin? So it exists naturally in body, synthesized by liver in inter-antitrypsin inhibitor ulinastatin antecedent form. It gets converted into liver to active form of drug. But in acute phase, it gets exhausted. And we really need this drug, ulinastatin, to control the inflammation, or to particularly in pancreatitis, to control the ongoing trypsin activity, to reduce the ongoing damage due to trypsin. How it works? It really inhibits the activation of neutrophil. It really inhibits the conversion of all antioxidant in injury, and it also reduces the pro-inflammatory markers. So what happens in acute pancreatitis, if I have to explain what is happening? What happens in acute pancreatitis? There is a ongoing early inflammation, there is a shinner injury, there is a ductal injury, there is a systemic inflammation. Since this trypsinogen gets converted to trypsin due to enteropeptidase, this trypsin further activates all inactive enzymes. So, and that causes autodigestion of pancreatic tissue, local tissue, and then systemic inflammation. This ulinastatin has a capacity to control the conversion of trypsinogen to trypsin, and also due to activation of lipopolysaccharide, this causes oxidative stress and releases the inflammatory marker of interleukin 1, interleukin 6, TNF alpha, and these pro-inflammatory markers needs to be controlled, and which can be controlled by ulinastatin by working as an anti-inflammatory, because this drug is an anti-inflammatory which works like. So it reduces oxidative stress, it reduces the inflammatory marker, and it also reduces the local damage of pancreatic tissue by working as an anti-trypsin activity. Now, do we have some data, or do we have some evidence to say this? So, group of patients where ulinastatin is used, and we tried to see the amylase and lipase level. It was found that amylase and lipase surge and sustainability was less in a group who were given ulinastatin, which is one of the marker of tissue damage in acute pancreatitis. Now, how does ulinastatin works as a summary? So, as I said, it reduces the local damage of the pancreatic tissue in acinar as well as ductal level. It works as an anti-inflammatory. It works at cellular level by inhibiting the activation of particularly macrophages and neutrophils. So ulinastatin, and it also works as an anti-inflammatory of interleukin 1, 6, which is a pro-inflammatory marker. So do we have enough evidence? So this is one of the trial where we're trying to look at the efficacy of ulinastatin in reducing inflammation and improving outcome in acute pancreatitis. What they have, it is a randomized controlled trial involving moderate to severe pancreatitis. Patients receive standard care along with ulinastatin, and what was found, there is significant reduction in inflammatory markers, that is interleukin 6 and TNF alpha, lower incidence of SIRS in a patient who received ulinastatin, and it also reduced the hospital stay in a patient and mortality in a patient who received this. This was the case for the first case, first small series case where efficacy of ulinastatin was assessed in reducing inflammation and improving outcome in acute pancreatitis. In other trial, ulinastatin for prevention of organ dysfunction in severe acute pancreatitis. It was a double-blind study with severe acute pancreatitis divided in ulinastatin and placebo group. It decreased the incidence of multi-organ failure, particularly in lungs and kidney. That's why, particularly, I also feel when there is a acute pancreatitis or maybe it is severe sepsis, and when there is a liver or kidney involvement, using acute ulinastatin in those group is more productive than patient who do not have liver and kidney involvement. Because if liver and kidney are involvement, it means there is a less and less anti-inflammatory, particularly ulinastatin is being produced by liver, and we need to give it more. Fewer incidents of ARDS and improved patient survival rate, especially when administered early in disease group. Ulinastatin as an adjunct therapy in acute pancreatitis, objective was to determine the impact of adding ulinastatin to standard care protocol. It was a multi-center trial with patients receiving standard therapy along with ulinastatin. Faster resolution of abdominal pain and digestive symptoms. Serum and mileage and lipase were reduced significantly in patients who receiving ulinastatin, and enhanced quality of life post-discharge, hospital, and reduced the rehospitalization rate. When we try to compare the ulinastatin with other anti-inflammatory for acute pancreatitis, comparing the efficacy of ulinastatin with other inflammatory agents such as octreotide and corticosteroid, this initially they were being used, but now nobody uses it. And it was found that comparative study with patients receiving ulinastatin, octreotide, corticosteroid, and placebo, ulinastatin showed comparable or superior outcome in reducing cytokine level. Patient in ulinastatin group had a fewer adverse effect compared to those on corticosteroid because corticosteroid has tendency to cause secondary infection, and that's why it's not used and out of fashion for acute pancreatitis. Does ulinastatin also improve the long-term benefit? Because some of the patient of acute pancreatitis will get converted, around 20-30% will converted to the chronic pancreatitis. And when we try to assess the long-term impact of ulinastatin therapy on recovery and recurrence rate, this was followed up post-acute pancreatitis for an year. It was showed that lower rate of recurrent pancreatitis in ulinastatin treated patient, improved pancreatic function, and reduced incidence of chronic pancreatitis, and fewer long-term complications, and improved overall quality of life. This is one of the trial where ulinastatin in the treatment of severe acute pancreatitis, a single center data, and this was the dose was used was around 4 lakh unit with in compared to placebo, randomized 1:1, 7-day treatment followed up for 30 days. Initially, it was they tried to see the mortality, inflammatory cytokine level, coagulation function, infection, and at the end, clinical efficacy safety was evaluated. Around 217 patients were seen, 19 patients in ulinastatin and 91 and 90 in placebo group. And what they found that patient who were given ulinastatin in severe acute pancreatitis has a better outcome and better improvement than and lesser of adverse event than who did not receive. So core tip from this study was one of the most prevalent gastrointestinal complication is acute pancreatitis, leading cause of hospitalization and death. It suggests that ulinastatin can reduce the risk of overall 7-day mortality in severe acute pancreatitis and associated with higher total protective against hyperinflammation. And it also did not significantly increase the incidence of severe adverse effect. One of the meta-analysis, a retrospective analysis, which was seen for ulinastatin, has shown that ulinastatin treatment was associated with improved outcome in patients with severe acute pancreatitis. So efficacy are different dose. So what is the dose? There are different dose were used: 2 lakh unit per day, 4 lakh units per day, and 6 lakh unit. And in this trial, it was decided that 2 lakh unit 8 hourly was the most effective dose for treating severe acute pancreatitis. And that's what the protocol we use. That if patient has severe acute pancreatitis, we give 2 lakh unit 8 hourly for 7 to 10 days as ongoing pro-inflammatory phase lasts in severe acute pancreatitis for 7 to 10 days in general. So these clinical trials suggest that ulinastatin is effective in reducing inflammation, preventing organ dysfunction, improving clinical outcome in patients with severe acute pancreatitis, especially when used early in treatment course. It's a very, very safe drug and very, very tolerated drug. Hardly any side effects. Some of the patient has noticed thrombocytopenia. Otherwise, apart from this, not a major side effect with these drugs. So in the last slide, my take on ulinastatin is that I use ulinastatin in all the cases of severe acute pancreatitis when I receive them in first 2 or 3 days, until unless they have go settle in multi-organ dysfunction and very well settled, no ongoing systemic inflammation other than in plateau or recovery phase, or maybe having secondary infection due to fungus or virus, that's different. But in early phase of acute ongoing SIRS response, a systemic inflammatory response, when patient comes to us in shock or severe multi-organ dysfunction, my take is that I start with two, along with pain control, control fluid resuscitation. The third drug which I use in acute pancreatitis in acute phase is ulinastatin 2 lakh unit 8 hourly. That goes for 7 to 10 days and subsequently in other. In fact, we don't need to give antibiotic in acute pancreatitis in initial phase, but this drug really can change, prevent, or reduce the ongoing complication due to acute pancreatitis. And if we do not use ulinastatin in acute pancreatitis, we potentially lose one of the drug which has potential to treat, potential to reduce the complication, and potential to reduce the mortality. So thank you for all your attention.
So thank you, Rajesh, for a short and a crisp, precise presentation on use of ulinastatin in acute pancreatitis. We'll be taking all the questions towards the end. I would go, and what a pleasure to invite the speaker for the second talk is Dr. Yash Javeri, who is a Director of Critical Care Medicine and Emergency Medicine at the Regency Hospital, Super Speciality Hospital in Lucknow. So over to you, Yash, and I request Yash to please speak on glimmer of hope in patients of sepsis with the use of ulinastatin. So
thank you, Dr. Subhal. Thanks for the kind words. I'll going to talk about sepsis glimmer of hope, and the presentation will discuss about various aspects of sepsis, especially inflammation, immunomodulators, why have we failed, and what do we have for treatment. Disclosure: no conflict of interest in terms of topic, product, or content. Have been on advisory board for ulinastatin and other related products, but do not promulgate use of any of the interventions which we'll be discussing. The views are mine.
Yes, your presentation is not on slide.
Okay, just a second, sir. Is it moving now?
No, it's not still in slideshow.
You should put it on a slideshow.
Yeah.
No. Go to home on the top.
Yeah.
And then
Slideshow.
yeah, there. And go from beginning, yeah.
Is it there now?
Not yet. I think try again. From current slide, try from current slide. Yeah.
Is it there?
No, there's some issue.
1 second, let us start again. Best thing is to start again.
Yeah, now it's full. Yeah.
And is it moving?
Yeah.
Oh, thank God. This is the biggest challenge. Okay. No disclosure of conflict of interest. The learning objectives of my talk will be to understand the theoretical basis, the clinical plausibility of use of ulinastatin, although much has been told about ulinastatin in inflammation by Dr. Mishra. We'll understand the need for immunomodulator, especially ulinastatin in sepsis. What options do we have for treatment of sepsis in terms of immunomodulation, like extracorporeal therapy, ulinastatin, or hydrocortisone, ascorbic acid, thiamine combination? How to use these therapies judiciously, especially ulinastatin? What is the real world evidence, and what is the way forward with usage of ulinastatin in sepsis? Sir William Osler, in his essay on evolution of medicine in 1904, except on few occasions, the patient appears to die from the body's response to infection rather than from it. So patients are not dying because of the microbiological load of, say, MDR, Acinetobacter. They are dying because of the physiological consequences like shock, hypoxia, organ dysfunction, which happens from infection. So our role as a clinician is not to sterilize the infective organs, but to stop the cascade of these physiological events which are happening because of the infection. In the background, inflammation is a necessary evil for sepsis. If there is no inflammation, the infections will never be clear. But there are side effects from inflammation. We all understand that. The role of inflammation in sepsis pathology is a double-edged sword. We all understand that. And most of the organ dysfunction which happens in sepsis is because of the double edge of inflammation. Because of this, the drug trials for sepsis have been a catalog for failures. Most of these drug trials have been targeting a single pathway of inflammation. But we understand there are multiple pathways. These pathways are redundant and interlinked. So even if we stop one single pathway, some other pathway will take over. So thinking about a monocausal therapy for sepsis or for any, for that matter, for any inflammatory disease is probably quite foolish. What we tend to achieve in sepsis is immunohomeostasis. Although we cannot be at the normal line, but we tend to be at a lesser degree of immune disarray for sepsis. The immune response in sepsis is uncontrolled, it is self-augmenting, it is generalized, it is non-specific. SARS and CARS both have consequences. Initially, the thought was SARS have higher mortality, SARS leads to organ dysfunction. CARS does not cause much of mortality or morbidity, but we understand there are secondary infections which happen in CARS phase, and there are other consequences of CARS phase also. And now, especially after COVID, we are now thinking about not only immunomodulation, but we are thinking about thromboimmunomodulation with various therapies. Over the decades, there have been several studies with various immunomodulators for sepsis. This particular meta-analysis was published in Marshall Group in 2008, and they compare almost 20 different therapies for sepsis, and none of these therapies showed any survival advantage for sepsis patient, and none of them was promising. So we always talk about making magic bullets. But having one right treatment or a magic bullet for any disease is an unscientific approach. We'll never have a magic bullet. We'll never have a holy grail for diseases as complex as sepsis or for that matter, any severe inflammatory disorder. Various therapies have been used: anti-TNF antibodies, IL-1 receptor antagonist, antithrombin, drotagoguin alpha, methylprednisolone high dose, and this was tifacogen. This was a trial which was published in 2003. It was thought to be a blockbuster molecule for sepsis. But again, a 17-country study of patients found no reduction in death from the disease and linked the drug to an increased risk of bleeding. Similarly, in 2005, Eisai sepsis drug Eritrea failed to save more lives in the final stage of study. Centoxin, this again was thought to be a multi-billion drug, but a multicentric European study again failed to show any survival advantage. No exception for Agenix as sepsis claims. Another hopeful victim, telectoferin. This was Stephen Opal's trial. The trial showed that telectoferin plus standard of care had a greater 28-day all-cause mortality than standard of care. Septic shock. Eli Lilly withdraws Zygris after 10 years on market. This was Shock Progress 3 trial, which again failed to show any survival advantage from Zygris, although this was in the market for say 6 to 8 years, but this phase 3 trial again failed to show any advantage. This is why often sepsis, especially the immunomodulatory therapies in sepsis, are called graveyard of clinical research. And this remains, the immunomodulation in sepsis remains the largest unmet need for us in the intensive care. So we need some form of immunomodulation for sepsis. What it is, we still don't know. Why do not we have a mini magic bullet for sepsis? Because there is media presentation, the timelines are vague, each patient behaves differently, there is redundancy and pleiotropy of mediators. There are 300 mediators of sepsis which we are aware of, but probably 100 or 1,000 more which probably we do not know. There is no single lethal process or a factor to target. We do not have anything like immunometer to know which phase of inflammation the patient is. So ultimately it remains a black box. The immune dysfunction in sepsis remains a black box. Don't fire until you see the whites of their eyes. What happens with most of these therapies? The small data groups showed some survival advantage, but the big data analytics failed it. And most of these therapies had some serious side effects, like bleeding or immunosuppression happening because of these therapies. And as we already discussed, the immune system in sepsis is still a black box for most of us. So we still need some form of immunomodulation. We want to bring the patient to a lesser degree of immune disarray. You cannot stop the waves, but you can learn how to serve them. Till now, we are having a generalized approach, but we are in an era of precision medicine. We need to find pathways. We need to target the right biomarkers at the right time, which can happen only with personalized medicine. Probably in near future, we'll have the right answers when to use each of these therapies in time. Till that time, we use this trident approach for sepsis. Antimicrobials are obviously the mainstay, multi-organ support therapy, and the third arm is immunomodulation. Immunomodulation could be with various things. It could be just with the source control, it could be with steroids, it could be with early enteral nutrition. Organ support is the main function of intensive care medicine. We essentially support the failing organ and give them time to regenerate. We do interventions to support failing organs. If the patient is hypoxic, we give oxygen. If the patient is having renal failure, we give some form of renal replacement therapy. We help strategize regeneration. We need to use such therapies which can help failing organs to regenerate. And we understand organ failure is time function. So we need to start these interventions as early as possible. We need to prevent AKI in ARDS, especially in the sepsis subgroup of patients. We need to achieve immunohomeostasis. So we need to have some form of organ support, and we need to avoid new onset organ failure in sepsis. So yes, we need some form of immunomodulation in sepsis. What is the right answer? We still do not have the right answer, but this is a burning question. Do we need it? The simple answer is a big yes. Bigger question is what works. Steroids has the largest body of evidence. Now, if the patient has septic shock, we start steroids. What, when, and where to use these drugs are still largely unanswered questions. Though the consolidated sheds of evidence of benefit of these therapies are yet to be established, the risk-benefit ratio is to be taken into consideration, as we discussed in the previous presentation also. Various immunomodulators are being used off-label with variable success to blunt hyperinflammation, but this should not become a cult science. We should always look at risk versus benefit, and we need to compare the benefit with effect. Some of these therapies will show you some effect, but it should translate into larger benefit like survival advantage. If not survival advantage at 6 months, at least discharge from ICU or weaning from ventilator. These should be the benefits which should be looking at. The options for immunomodulation. Either we can have a general approach to immunomodulation like early enteral nutrition, a good source control, non-selective immunomodulators like we talk about ulinastatin, thymosin, and various other therapies. Steroids also come in the same bracket, or immune augmentation strategies like neutrophil infusion, and there are various other interventions in this immune augmentation strategies. Now we are talking about non-selective immunomodulation with ulinastatin. What is ulinastatin? It's an acidic glycoprotein. It's a broad spectrum protease inhibitor. There are various protease inhibitors which are commercially available, but ulinastatin is a broad spectrum protease inhibitor. As it is a broad spectrum protease inhibitor, the utility comes in various disease states. It could be from an autoimmune vasculitis, it could be for pancreatitis, it could be from some jellyfish toxicity, it could be for pancreatitis, it could be for sepsis, it could be for ARDS. Because it is a broad spectrum protease inhibitor. Developed well way back in Japan in 1970 and has been approved in various countries now. Already discussed by Dr. Mishra, so I'll not go into detail. However, what I'd like to highlight here, it is a broad spectrum protease inhibitor. It decreases the TNF level, IL-6 level, IL-8 levels, CRP levels, IL-2 and interferon gamma levels. So the pro-inflammatory cascade is gradually blunted with ulinastatin. What happens in sepsis? Non-specific systemic inflammatory response is high, specific immune function is low. With ulinastatin, the cytokine level, especially the pro-inflammatory cytokine levels come down, the humoral immunity improves, the cellular immunity also improves, and this all translates into immunological function improvement, lesser organ dysfunction, and improved survival rate. Dosing, there has been a lot of discussion. Too early versus too late. If we start any therapy too early, probably it will be difficult for us to understand, is it the standard of care that is benefiting the patient or the therapy? Too late, if the patient is already on 2 vasopressors, we have already missed the bus. So now sepsis we define as single organ dysfunction because of infection. If the second organ has starting to fail, that is the best phase of sepsis where you should start ulinastatin. However, high-risk patients who are not improving with the standard of care therapy, where you think the risk of death is high, you should contemplate to start ulinastatin. So timely is second organ dysfunction. You should not be late than this. Standard dose for sepsis is 2 lakh units, 12 hourly. There was a lot of skepticism surrounding the dose of ulinastatin, but post-COVID, we are wiser with understanding of the dose. If inflammation is severe, you can use higher dose. If inflammation is prolonged, you can use a higher dose. If inflammation is for a short while and after 2 days of patient improves, you can probably at times stop after 2 days of therapy. The dose also can be higher, depends on the severity of sepsis. 2 lakh unit 12 hourly is generally followed because that was the conventional dose used for the initial research papers. Again, the dose has to be individualized and we have used doses up to 6 lakhs and 8 lakhs 24 hourly for sepsis patient. Depends on what subset of sepsis we are talking. Patient selection for adjuvant therapy, we have to follow the surviving sepsis care bundles very, very religiously. Our basics have to be right, then only we should be jumping for such therapies. Patient selection, the timing of the therapy, the phase of the disease, pro-inflammatory phase, it is more useful. It could be biomarker guided. Early versus late, we already discussed. Duration, again, it could be a prolonged discussion also at times. Severity of sepsis has to be thought of. If a fresh patient comes to your emergency, you give some fluid resuscitation, the patient improves, probably that is not the right subset of patient. Risk of death. This is single most important parameter which can guide you in decision for any adjuvant therapy. If the risk of death by objective or subjective criteria is high, you are justified in using any of the adjuvant therapies. Biomarkers and futility of care should always be in back of the mind. So this was the general understanding for adjuvant therapy, especially for extracorporeal therapies. If the Apache 2 score is more than 25, then use these adjuvant therapies. But Apache 2 more than 25 has very, very high mortality. And now we have moved on to somewhere 15 to 20 of Apache 2 score or one organ failure. Sepsis-induced organ failure, if septic shock is there, sepsis-induced ARDS, sepsis-induced GIC, these subset of patients we should be starting early. No absolute contraindication, you have to weigh relative contraindications. There are obviously no major contraindications unless the patient has a known allergy to ulinastatin, and which I have never encountered, and I don't think anyone else would have encountered this. Already discussed this subjective criteria, objective criteria. The clinical profile, hemodynamics and oxygenation profile, the hemodynamics are worsening, the oxygenation indices are worsening. The physiological trends with the standard of care, response to standard therapies. These are again important thing. You see the trend of the patient, you do the biomarker levels. If the patient is physiologically deteriorating and the biomarkers are also showing a similar trend, that is the best window of opportunity to use these therapies. Some evidence, this is the biggest paper, landmark paper, which came from India about use of ulinastatin in severe sepsis. This was a multi-center randomized control study published in Intensive Care Medicine 2014. The objective was to study the effect of ulinastatin on 28-day all-cause mortality in a double-blind trial in patients with severe sepsis in 7 Indian hospitals. The terminology was severe sepsis those days, so that terminology has been used. Adult patients, double-blind randomized placebo-controlled study. They were randomized within 48 hours of onset of one or more organ failures to receive IV ulinastatin or placebo 12 hourly for 5 days. 122 patients, IV infusion of either 2 lakh units ulinastatin or identical placebo over 1 hour every 12 hourly for 5 days. The key results, one point I'd like to mention here, you have to give this as an infusion of 1 hour. If you tend to give it very fast, there could be side effects like shivering, rigor. So be aware about this. Always mention it clearly over 1 hour. The key results were 28-day all-cause mortality 7.3% with ulinastatin 4 deaths versus 20.3% in placebo group. Lower incidence of new onset organ failure 10 versus 26. All of the studies, regardless of what disease we are talking about, either it is vasculitis or Takayasu or pancreatitis, ARDS or sepsis, this is a common finding in ulinastatin subgroups. The new onset organ failure is less in all the subgroups. More ventilator-free days and shorter hospital stay. Although there were some discrepancies that the Apache 2 score was too less for a severe sepsis patient, but these are the findings what I presented here. Some other evidences from various parts, most of it is from China. 2015 Chen et al. 2 lakh 12 hourly for 7 days, 50 patients. Dai et al. Again China, this was again an RCT. Severe sepsis 2 lakh 12 hourly for 5 days. Wu et al. From China, 2011-12, 2 lakh units 8 hourly for 8 days. So the dose, the duration varies depending on the severity. This is what we presented at ECMID in 2015. We actually presented 2 papers in the same year with ulinastatin. The first one was usage of ulinastatin in patients with severe dengue admitted in ICU. And the second one, which we'll be discussing now, is role of ulinastatin as an adjuvant therapy in patients diagnosed with severe sepsis of varied etiology. This was a multicentric study, observation study performed from August 2013 to 2014 at a 24-bedded ICU multi-specialty hospital. Severe sepsis of varied etiology. The primary objective was to assess the impact on outcome with ulinastatin in severely septic ICU patients. 28-day all-cause mortality was the primary endpoint. The secondary endpoints were hemodynamics optimization and shock reversal, AKI, PF ratio, and to evaluate which patients on the basis of the etiology and disease stage could benefit the most from therapy. 220 patients with severe sepsis with varied source, abdominal sepsis, thoracic, urinary and soft tissue infection enrolled over 2 years. 2 lakh units, 12 hourly, 5 days. 100 patients received ulinastatin in addition to the conventional therapy, whereas the other 120 patients were in the control group, given only the conventional therapy. 28-day all-cause mortality was 20% in the patient treated with the ulinastatin group, compared to 35% in control, which did not receive any immune therapy. New onset organ failure decreased from 33.33% in the control group to 24% in a ulinastatin group. Improvement of hemodynamics and time to stoppage of vasopressor were comparable in the 2 treatment groups. There was a statistically significant reduction in average length of stay in survivors. Patients in whom ulinastatin therapy was instituted early, within 24 hours, had better outcomes than those where therapy was instituted after 24 hours. How can we use ulinastatin judiciously in the coming years? We have to individualize our choices. We have to individualize which patient could benefit most. Utilizing various biomarkers, we can use a biosignature panel of these biomarkers. We need to integrate AI, especially the clinical parameters, the patient clinical profile, and the biomarkers, then decide on which therapy to use. Theranostics means to use a therapy under guidance of biomarker level and then see the response, see the biomarker level after the therapy and the clinical response after the therapy. We need to determine the right subset and timing of the therapy. Some patients will benefit if we use it very, very early. Some patients we can wait. We need to have the surrogate endpoints for big data analytics. 6 month survival benefit is not the right endpoint for any of these RCTs for immunomodulation in sepsis. We need to look at parameters like hemodynamics optimization, length of stay in the ICU, and easily achievable targets. We need to follow a combinatorial approach with various adjuvant therapies in sepsis like steroids, ulinastatin at times, extracorporeal therapies, and whatever else has evidence. The practice points: ulinastatin has firm physiological rationale. We must understand when, what, and how to use. Judicious usage is required. We need to follow an individualized and personalized therapy. We need to have a dynamic view of sepsis so that we can use these therapies in the right subset of patient. We always need to remember absence of evidence does not mean evidence of absence. We need to decouple RCTs. We need to look at surrogate endpoints and we need to evolve the evidence at times by looking at 1 year survival. Probably we are desiring too much for therapies. These are no magic bullets and we should be looking at achievable targets. Thank you for the kind attention.
Thank you, Yash, for an
Thank you, sir.
extensive
Thank you,
and
sir.
nice, precise presentation, which covered almost all the aspects about ulinastatin. So we'll take the questions towards the end. We'll
Right.
move to the third and the final talk by Professor Dr. S Nayak, who is the Director and HODA of Nephrology Department at the Virenchi Hospitals in Hyderabad. And I request Dr. Nayak to speak on the role of ulinastatin in renal indications. What is the real worldwide experience? So over to you, Dr. Nayak.
Thank you, Dr. Subhal, and thank you all the attendees for attending this rather late working day webinar. I'm going to speak on ulinastatin for renal indications, the real world experience and recommendation. By real world, I mean not going more by data, but our personal experience and how to use it, because we have been using ulinastatin for quite some time now with favorable results. And so I thought it is time I shared this. We have presented this data for novel indications, just extrapolating the mechanism of action of ulinastatin. I can say upfront that there is a little bit of hesitation on part of the clinician to use these drugs, immunomodulators, because of the unpleasant things that happen with Zygris, drotricogene activated protein C, which, in fact, to tell you the truth, the FDA was very hesitant to the FDA approval came in 2002, but the advisory committee, which consisted of 20 members, 10 of them objected to its the evidence and were against FDA approval. But we all think FDA is incorruptible, but they gave the clearance in 2002, and we have used it, and we have suffered because of Zygris. Patient have bled to death intracranial. So the evidence was finally the FDA withdrew the approval, and Zygris was withdrawn by Eli Lilly in 2011. So there is a hesitation, and I would say that this is one single important fact that probably leads to a kind of a hesitation by the clinician. So I thought we should give you our evidence of the usage of ulinastatin in patients with renal failure of various causes and our results. So the outline presentation would be a brief introduction. My previous two speakers have done a great job of that. I will talk about sepsis and AKI, PD, peritoneal dialysis peritonitis, which is becoming PD is quite an accepted therapy worldwide and in India. And Ulinastatin in post-transplant patients with severe sepsis. And then I'll summarize and then I think it will be time for all three of us, and Subhal will moderate the questions. So outline, Ulinastatin as a protease inhibitor. This has been, the cartoons are showing the cartoons are showing the I'll just summarize it. The systemic inflammation triggered by infection, these infection trauma or autoimmunity, they release serine proteases. These are key intermediates which regulate intracellular and intercellular signaling, amplifying inflammatory cascades. So this is what happens. You can see in the three various ways that the cascade is initiated, and protease, serine proteases are key in that. So protease regulation, the body produces protease inhibitors by itself to balance excessive protease activity, which can be damaging in sepsis. So ulinastatin, which is a urine trypsin inhibitor, you might see short form UTI. It's not urinary tract infection, it's urinary trypsin inhibitor, which is the commonest source for the commercially produced ulinastatin. This one both in the blood and urine, and reduces pro-inflammatory response and inflammatory cytokines. So there is an initial insult, which could be anything from dengue to any bacterial autoimmunity. So that leads to the commonest way we know there's an infection is fever, progresses to is it inflammation, is it regulated or not? Has it gone beyond the body's ability to control the proteases? It goes to SIRS, the systemic inflammatory response syndrome, and ultimately multi-organ dysfunction syndrome, which leads to most of the times mortality. What ulinastatin does is this, you could say it acts both ways. It reduces the anti-inflammatory cytokines, and because of that, it can it blocks the IL-10 and IL-13. So it has a salutary effect on the cascade here, and it also decreases the pro-inflammatory cytokines, which is IL-1, TNF alpha, IL-6, and IL-8. So these are the biomarkers which are present in the body, and so I think it was the word immune homeostasis. I like that word. That is what is the role of ulinastatin. So ulinastatin counteracts serine protease inhibitors and reduces the. In addition, it reduces the. I'm not able to see my slide. It reduces other mediators of inflammation such as plasmin, neutrophil elastase, and thereby reducing the inflammation and recovery from a serious infection. The accepted clinical indication for ulinastatin pancreatitis, where it reduces inflammation and inhibiting protease that exacerbate pancreatic damage. Rajesh has spoken in detail about that, using toxic shock syndrome, using Stevens-Johnson syndrome, toxic epidermal necrolysis, and we have already, Yash Javeri has spoken, Yash spoke about the immune homeostasis, which is a critical component in saving a patient from severe sepsis. I agree with the with Yash that the Apache score 2, which is the commonest or the SOFA scores, are very high as indication for usage of ulinastatin. It should be lowered because we have to start early, and our studies have shown that. So in sepsis and ACAM, coming to our so initial studies were done in the preclinical studies in animals. The cisplatin nephrotoxicity model clearly showed that the kidneys are protected, they reduce azotemia and prevent tissue damage. And then the renal ischemia reperfusion injury, which is the rat model, it reduced, it enhanced BCL2, which is B-cell lymphoma expression, and big shock protein is reduced, and also the mitochondrial protection. This study has been in depth discussed by Yash, and this is you should note that this is an Indian study and one of the very few studies which is a randomized control trial, a multi-center trial, and it was published in one of the prestigious journals, Intensive Care Medicine Journal, with an impact factor of 27.1. They have a couple of studies on ulinastatin, and we can say with some kind of certainty that ulinastatin as an effective treatment for sepsis and septic shock is effective. I mean, whenever there is shock and sepsis, there is an AKI. So it's logical that when we speak of AKI, there is sepsis. And so it became a logical progression for us. We've been using this for more than a decade now, ulinastatin, and AKI became our target and for our other indications too. Now, this is a systematic review of meta-analysis of randomized controlled trials. This came in 2019, 13 randomized controlled trials and 2 prospective studies before 2018. So a total of 1,358 patients with sepsis. It significantly reduced all-cause mortality, and it reduced the incidence of multiple organ dysfunction syndrome, reduced serum levels of IL-6, TNF-alpha, and there was no adverse effects as in Zygris, which led to the bleeding. So there's no doubt that in sepsis it works. So this is our own study. Our study, which was published, presented at the World Congress of Nephrology in 2017 in Mexico. The prospective observational study over 24 months, renal failure, which is AKIs, CKD on medical management, dialysis patients, and post-transplant patients with sepsis were treated. And the ulinastatin group, 47 patients got 2 lakh. We followed the standard dose, that is 2 lakh units of ulinastatin twice daily for 5 days. And we compared 96 patients without ulinastatin. Data collection with the Apache 2 scores before and after therapy, organ dysfunction parameters, and renal failure types. You can see the renal failure types. I'll come to that later. So there was respiratory failure. It so happened that we started very early, and the respiratory failure rates were less in the ulinastatin group. But if you see the number of organs involved, there's no statistical difference. And then the renal failure predominantly were AKI, medical management, those on hemodialysis, those on peritoneal dialysis, and those post-transplant patients. There was a lower, and if you see here, the vasopressor used was, this is at start, 76.9% of ulinastatin group, 80%, but that was statistically not significant, so the equal number of patients. Mechanical ventilation definitely was lower because we believe in using ulinastatin earlier than later. So, in summary, lower incidence of respiratory failure, reduced hepatic dysfunction, and lower rates of AKI and CKD on medical management in ulinastatin group. There was a higher incidence of patients of renal transplant receiving renal transplant in the ulinastatin group. The source of infection, we saw respiratory infections almost a little bit higher in the control group than genitourinary. These were all the causes of sepsis: gastrointestinal, skin, and CNS. You can see the histograms here. And gram-positive infections and gram-negative infections, very few fungal infections, almost the same in both the groups. So our results, key findings were 14-day all-cause mortality for 5, that's 12.8% in the ulinastatin group, whereas it was 31.9% in the control group. So that's very statistically significant. Mortality in the subgroups, if you see no patient with AKI in the group on ulinastatin had a mortality. CKD on medical management 0, statistically significant. The only interesting thing was those on home hemodialysis, I mean, on maintenance hemodialysis, there was no statistical difference. Those on peritoneal dialysis, we had, again, not much. I mean, we had a statistical 0.02. Post renal transplant was very, very useful indication. And the duration of vasopressor, number of days, 1.7 in the Ulinastatin group, I'll call it UTI group, and 3.2, so statistically significant. Lower incidence of new organ dysfunction, this has been mentioned by our previous speakers. Significant reduction in the need for vasopressor and ventilatory support. So it's pretty clear cut here. I have put it in red specifically. 1.7 inotrope support, number of days, and 3.2 here. Duration of mechanical ventilation. Of course, we used ulinastatin in patients who did not reach the stage of mechanical ventilation. Ventilation 3 days, 8.7, and duration of hospital stay also very low. This was a study published in Critical Care, a pretty prestigious journal. They also showed AKI incidence after cardiac surgery to be very low. Renal replacement therapy, lower need in UTI group, and no difference in mortality, ICU stay, and hospital stay between the two groups. Protective role, UTI, ulinastatin reduced AKI risk significantly. And another study in patients undergoing off-pump cardiac bypass surgery, there was clear-cut evidence that the length of ICU stay was significantly reduced in the UTI group, and the creatinine, serum creatinine was significantly lower, though the starting creatinine in the OPCAR group was the same in both groups. So this was a study that was done. This was not done in China. This was done in Korea, and Korea is known for its high level of clinical papers and academics. This was ulinastatin for AKI published in 2023. They had 200 patients, 100 on with AKI who needed ICU care, 100 were on 3 doses of ulinastatin, 3 doses, that's 6 lactams for 5 days, and 100 were on 100 were on standard of care. So 2007, 2020, the various etiology, malaria, enteric fever, urinary tract infection, dengue, pancreatitis, and everything. They recorded the length of stay, need, and duration of renal replacement therapy, time to stoppage of renal replacement therapy, need for mechanical ventilation, mortality, and post-AKI recovery and progression to CKD was significantly shorter for patients receiving ulinastatin. So it showed promising benefits in reducing ICU stay and renal replacement therapy and improving renal recovery. So I'm coming to this, we are pioneers worldwide, ulinastatin in peritoneal dialysis and peritonitis. We, as an adjunctive therapy, did 2 studies. One, this was the adjunctive therapy in peritoneal dialysis related peritonitis with sepsis. Especially the children and the elderly are very susceptible to sepsis, that is septicemia, from a PD peritonitis. So this was a prospective open label observational study. 46 PD patients with peritonitis, 21 received UTI, 25 was the control group. The dosage was as standard dose of 2 lakhs for 5 days. So you can see here significantly shorter hospital stay, significantly lesser duration of vasopressor support, lower incidence of new onset of organ failure, and lower 14-day all-cause mortality. So as an adjunctive therapy, it's really extremely good in PD-related peritonitis. This was a second study which we have submitted and accepted for presentation at the World Congress of Nephrology, which will be in February 2005 in Delhi. This is the one where we have used the molecule we are discussing now in the late half of the study, the lyophilized form, which we find it very convenient to use. So patient age more than 18 years with PD peritonitis, either on PD or the ambulatory peritoneal dialysis, that is, they don't use the machine, and the automated peritoneal dialysis. We are one of the world's first centers to start using immediate start peritoneal dialysis. We put the catheter, and within the hour we start them on peritoneal dialysis, and we are going to do a randomized control trial comparing automated peritoneal dialysis to CRRT. So the groups were the standard of care alone, and standard of care plus Ulinastatin, the standard dose. Baseline assessment including HSCRP, procalcitonin, and PD cell count. Follow-up after 5 days of the Apache 2 score and lab assessments. You can see here the mean age was the same. Male-female ratio was also not different. Incidentally, the UTI group had higher comorbidities such as type 2 diabetes, hypertension, and coronary artery disease. Starting creatinines were the same. Apache scores were 17 and 16. HSCRP, you can see it went slightly higher in the Ulinastatin group. Procalcitonin was 9.44 and 10.82. And PD cell count, more than 100 cells is sine qua non, one of the most important diagnoses of peritonitis. It was the same in both the groups. And after 5 days, you can see an amazing improvement in the Ulinastatin group. The Apache score came down to 7.21. It was 12 in the standard group. HSCRP came down to 2.22. It remained high here. All are statistically significant. Procalcitonin came down, and the PD cell count almost all recovered from the peritonitis. As I told you, 100 cells per cubic millimeter. Here it remained around 100 and plus. The Ulinastatin group showed improved inflammatory markers and remission of peritonitis. The post-transplant, we published this in the Indian Journal of Transplantation. All 6 post-transplant patients were admitted. 8 patients we had the same dose we used, Apache 2 scores typically. The duration of the illness varied from 24 hours to 7 days. We were given IV antibiotics and supportive therapy, and were assessed day 5, day 10, and day 15. So these were the patients actually. I won't go into the details, but there were 8 cases we used this at that time, pure renal transplant patients. The various source of infection, pneumonia, abscess, gastroenteritis, wound infection, and etc., septicemia in everyone. Apache 2 scores were pretty high, 19, 21, 16, 30. These were 8 patients. We used Ulinastatin. There was no other group without Ulinastatin. So out of the 8 cases, case number 2 died on the 3rd day, and case number 5 died on the 4th day. So 6 patients made complete recovery and had their renal function restored to normal. Of the 8 patients, 2 succumbed, and HSCRP came down. Inotrope by the 15th day, they were discharged. You can see all of them, 6 patients discharged. And the 2 of the succumbed patients were presented to us 48 hours after their initiation of sepsis. As Yash said, treatment should be initiated within 24 hours. So that was the reason probably. So to conclude, when used early as adjunctive therapy, Ulinastatin has been shown to reduce mortality, morbidity in sepsis patients, including those with AKI, CKD, PD peritonitis, and renal transplantation. The treatment cost is 75,000 if you use the standard dosage. And I think this is a one-day stay in ICU. It's sometimes about 75 to 80,000 or maybe a lakh. If you are using ventilator, you are using PRRT, close to 1.5 lakhs. So 75,000 is a very economical option as a therapy. And I would strongly recommend that all our attendees, when you have, don't start late, start early, and don't wait for respiratory failure even before that. And just see the response that you get. Any sepsis with the AKI, I would recommend, because our experience mainly with that, but pure sepsis definitely, Yash has given you enough data. Pancreatitis is a confirmed indication. So in summary, it's a serine protease inhibitor. UTI reduces inflammation, supports organ recovery in critical conditions like sepsis and AKI. In renal sepsis and AKI, ulinastatin shortens ICU stay and reduces renal replacement therapy needs. Cost also comes down significantly because of this and offsets the cost of ulinastatin, which is actually not 75,000 per day, but 75,000 for the entire course, which is nothing compared to reducing offset by the reduction in RRT needs. Ulinastatin use, we were the world pioneers in using it in PD-related peritonitis. As I said, young and old people tend to succumb to PD peritonitis. Potential benefits in post-transplant sepsis, and we need larger randomized controlled trials to confirm its role as standard adjuvant therapy in critical renal and sepsis management. Thank you, one and all, for your patient hearing.
Yeah, thank you very much, Dr. Nayak, for giving an extensive presentation on the use of ulinastatin, especially in renal patients with post-transplant, and also covering the aspect of dialysis into it. And it was very nice that you presented your own original research studies that really made it very interesting. So we move on to the next part, which is as far as the panel discussion is concerned. We have seen and learned from Dr. Rajesh Mishra, along with Dr. Yash Javeri, and from Dr. Nayak, what are the different indications where it can be used. We have got a eminent panel along where we can have more expert opinion, where these faculties can again join the elaborative panel. Without wasting much time, I would like to invite the first panelist, Dr. Kapil Zirpe, who is the past president of the ICCM, who is also the president of the Sepsis Forum, and he's also the director of neurocritical care at Rubiol Clinic, Pune. The second panelist is my pleasure to invite Dr. Saroj Kumar Prusty, who is the HOD of critical care medicine at tertiary care hospitals in Hyderabad, and Dr. Rajib Paul, who is at the consultant and HOD of critical care medicine in the Apollo hospitals, again in Hyderabad. Of course, we have got the expert panels of Dr. Rajesh Mishra, Dr. Javeri, and Dr. Nayak. So without wasting much time, I've got a few questions which I've really prepared as far as the discussion is concerned on to the use of ulinastatin and how it should be really used into it. So without wasting much time, I'd like to go ahead with the first question, asking to Dr. Zirpe, okay, what is his experience about immunomodulators, and what do you think immunomodulators are, and do you use it, Dr. Zirpe?
Yes, well, thank you. Thank you for the inviting and introduction. See, immunomodulators is not a new to us. We all use it in a day-to-day practice. Immunomodulator itself gives you the idea. They modulate the immunity. So, if you see there are the various substances we use in our day-to-day practice to modify that immunity of the system. So, there are two types of the immunomodulators. Either they are immunostimulant or immunosuppressive. Specific, non-specific, that is a different classification. So in certain situations, we want immune system to be more active to defend our own body. That is the immunostimulant, and generally they enhance the defense mechanism of the our human body. Generally in a cancer or infection patients, we can use those immunostimulant. So a good example is the vaccines. We give vaccines to stimulate your immunity and just create your protective body mechanism. On the other hand, there is immunosuppressant. Now this immunosuppressant we have used left and right during the COVID. So now the immunomodulators and immunosuppressant, basically they suppress the immunity. So sometimes there is a overreaction of our body immunity, and we need to suppress that overactivity. Or in your transplant patient, to prevent rejection, they can be used. So these are the known as immunomodulators. So these are the drugs. There are various drugs. There are the vaccines. They can be used either immunostimulant or immunosuppressant. And the second question is, do you use it? Yes, of course, we use it in a day-to-day practice. Like the first indication is acute severe pancreatitis. It is now the evidence-based indication for the ulinastatin. Again, the timing of the ulinastatin matters. If you use it in an early phase, it is always better. Like in a sepsis, even in a septic shock with AKI are the indications for the ulinastatin. So during the COVID, we have used in first 72 hours. So these are the indications where in current situation, I'm using the Ulinastatin.
Yes, thank you, Dr. Zirpe, for exactly precising how do you use it, where, and what is the real timing about it, and covers about what are the role of immunomodulation. And most importantly, the use of these immunomodulation really dysregulates, they really help to regulate the dysregulated host response, which is really being generated with the help of cytokines. So the second question I would like to ask Dr. Saroj Prusty, what are the different types of immunomodulators you think will be the real game changers in the management of sepsis or in critical care?
Yes, sir. Yeah, good evening to one and all. So, immunomodulators, as Kapil sir clearly defined broadly, by mechanism wise, they are divided into immunostimulants or immunosuppressants, and they act on specific target wise and part of immune system. So, they helps broadly. They are divided into like immunomodulators for the cancer related immunomodulators, autoimmune disease related modulators like our use for SLEs, collagen disease, rheumatoid arthritis, and different autoimmune disorders. Immunomodulators related to the allergic conditions, inflammatory bowel disease conditions, and immunomodulators related to inflammation and infection. So like that, different immunomodulators are there. But mechanism wise, when you use as an immunostimulant, sir has given the example, and immunosuppressants are there, we probably divide like biologics. So we use the term as a biologics, which are being from the natural resources being manufactured. So examples, these protease inhibitors are examples, clear examples of it's a kind of biologics. So they helps different protease inhibitors. Even Dr. Yash told regarding the one is our ulinastatin is one of the important drug. Besides that, aprotinin is also one of the important drug. Gavaxet mesylate is also one important drug. Somatostatin is also a protease inhibitor. So many drugs are there. But we are discussing regarding the ulinastatin related conditions where we can optimally use the ulinastatin. There are so many literatures data regarding the sir has presented, Mishra sir has presented, Nayak sir has presented, and the Yash sir also has presented so many data on the ulinastatin, so that it is, we can say that it is underutilized compared to the different successful indications for the usage of the ulinastatin. That is one group. Regarding the other immunomodulators which are being used for the autoimmune diseases, like you might be knowing that we have different biologics like tocilizumab, we have rituximab, we have infliximab. So these are the kind of the drugs which different CD cells they have help in the immunomodulation. And besides that, interference also used for different multiple sclerosis and other conditions where it helps for the immunomodulation. And thymosin alpha is also a good drug for which helps in chronic conditions of hepatitis B and hepatitis C. So it is also helps in immunostimulation. So these are the different kind of immunomodulators.
You have different molecules, right, from tocilizumab, itolizumab, ulinastatin, thymosin alpha, which are really used for immune modulation as such, right?
Yes, sir. Yes.
Yeah. So without this is excellent way that to cover it up. Of course, the mechanism of actions of everybody is going to be different. Of course, steroids also do play an important role as a part of immunostatin. But more importantly, sticking to critical care, we will definitely be sticking more on to ulinastatin over and above the other toxic forms of the tocilizumab or the itolizumab forms. So Rajib, I would like to ask you, do you really use ulinastatin in your critically ill patients, and what is the concept behind using ulinastatin?
Thank you, Dr. Subhal, and all the speakers and the audience. This is a very interesting discussion that we had, and I have been a major user of immunomodulation in the last 24 years of my practice as critical care and internal medicine, and starting from steroids to use of Zygris, and subsequently have been the major proponent of use of cytokine filtration in the country. So Ulinastatin, yes, we have used through a phase of Ulinastatin, but my use has been mostly till now towards the pancreatitis subgroup, severe pancreatitis, where we use Ulinastatin early stages, and we have seen lots of in patients improvement. The whole concept behind Ulinastatin, basically what all we have discussed till now, being a glycoprotein which is isolated from healthy human urine, and it acts as a urinary trypsin inhibitor. So technically, it was initially for the trypsin inhibition and the severe effects of pancreatitis. So to reduce or the harmful effects of acute pancreatic degradation causing secondary bacterial translocation and septic shock, this drug looked like a magic drug, and it did work for many cases of pancreatitis if used in the correct time. However, but recently there has been a lot of talk on use in as a immune modulation that we're discussing today. And in septic shock, sepsis and septic shock, burns, and other inflammatory mediators, where other inflammatory mediators or cytokinemias are significantly high, this can be an adjuvant therapy in such scenarios. And basically, as we discussed in the presentations, it suppresses the pro-inflammation and also augments the anti-inflammation. So basically restoring the pro and anti-inflammatory balance. As we discussed that a pro-inflammation, early stage of severe pro-inflammation is what can lead to early deaths, and late deaths can be because of continuous activation of the anti-inflammatory system. So this drug basically will work predominantly on the pro-inflammatory cascade. Obviously, it also acts on the anti-inflammatory cascade, trying to achieve a balance. And so cytokinemia, the modulation of the cytokines, IL-6, IL-1 beta, and IL-6, IL-10 also, ultimately should achieve a good immune modulation to help a patient of sepsis or any other kind of severe inflammatory disease like polytrauma or drowning or other cases where
In short, you mean to say the concept is to have the dysregulation is to regulate it and take care of the inflammatory
correct.
mediators from progressing into an organ dysfunction. So really
Correct.
speaking, it's mainly the upregulation of the of the downgraded response or the downgradation of the upregulated response to produce a good harmonious balance to avoid or suppression of the inflammatory mediators. In short, that is real concept behind the use of these immunomodulations, so that the progression of organ dysfunction does not occur, and that's how there will be a reversal of sepsis as such. So thank you, Rajib, on this. So we move on to the next question and the expert opinion from Dr. Nayak. What do you think? We know it is available in the liquid form as well as in the lyophilized powder form. So what do you think is more advantageous, and what are the advantages and disadvantages have you observed in your practice? We are running slightly short of time. I request you to please stick to your time.
Yeah. Subhal, thank you for the question. I think this is a very important, pertinent question. The liquid form needs cold chain maintenance. It needs preservatives. And we found it very difficult, especially in summer with the Indian unpredictable transport infrastructure. So the lyophilized form we have been using for the last 1 year, and we actually have seen much better results with the lyophilized form because we know exactly the dose we are giving. There's no wastage as in the liquid form. And in short, I think I've been relieved, and I would strongly recommend that you use the lyophilized powder instead of using the liquid form for the reasons that I've already told.
Yeah, mainly the stability, and it doesn't require the cold chain. That's most importantly as far as this. So Rajesh, I would like to really speaking, you have did covered about pancreatitis. We did hear about use into sepsis. And do you use ulinastatin in your practice? I want a real honest answer.
Yes, well, I said it very clearly. I use ulinastatin. I use it very frequently. For pancreatitis, wherever I get patient early, I definitely use, and it has really helped me in reducing the progression of disease, improving outcome, reducing multi-organ dysfunction, even in sepsis. But of late, the only limitation has been cost, because I personally feel
And
ulinastatin
what dose do you prefer to use? 1 MU or
in
2 MU?
sepsis, I use 1 MIU BD. In pancreatitis, I use 2 MIU 8 hourly.
Okay.
But the cost has been a major hurdle for me, and all the companies have unnecessary. It's ultimately adjuvant therapy,
Do you
not
do any
definitive.
renal adjustments? Is dose
No renal adjustment. No
no,
adjustment is
that's
needed,
a
sir.
very
No.
important aspect here.
Yeah,
Yeah.
yeah. No renal, no hepatic adjustment is needed. It gets self-metabolized, so you don't need to adjust. And particularly if renal and hepatic involvement is there, most of the time I have seen that group of patients recovers better than those patients who do not have renal and hepatic involvement. So that's another observation for me. But I will still say that I keep on asking all the company who come to promote this product, me like unnecessarily the cost is increased too much for particularly Indian subset. So we need to cut down the cost of this molecule.
Yeah. So thank you, Rajesh. Yash, what do
Yeah.
you think? We know that this is a protease inhibitors. We are really speaking, I would like you to, this is actually a repetition of what we have seen from the previous talks. The mechanism of action, can you just repeat it
Yeah.
in short?
Yeah. Thank you. It inactivates many serine proteases, which include trypsin, chymotrypsin, kallikrein, plasmin, granulocyte elastase. It also improves the humoral immunity, not only decreases the pro-inflammatory mediators, but improves the humoral immunity. It also has its effect on endothelial dysfunction. That is why the usage in sepsis is there. As it is a broad spectrum protease inhibitor, so we see the utility and clinical indications in widely varied diseases.
Right. So thank you, Yash.
Thank you.
So Kapil, I would like you to tell us you have used it into these areas. Have you seen any major side effects with these use of immunomodulation or ulinastatin in your practice?
No. As such, the side effects are very minor one, like nausea, vomiting, abdominal discomfort. But you should be careful in a AKI patients. You need to be careful while using the doses. You need the dose adjustment in a AKI patient. And second thing, sometimes they are infusion related and the allergic reactions leading to the anaphylactic has mentioned in the literature. So we need to be careful while giving these drugs, though the side effect profile is very universal and the minor one. So these are the things, but personally, I never came across any side effect of the ulinastatin in my practice in last so many years.
So most importantly, the typical amount of anaphylaxis or the hypotension, what you commonly see with tocilizumab, itolizumabs are not commonly seen much with ulinastatin. It's a much more safer drug as compared to the other forms of immunomodulation. I won't go into these certain questions, and we know that we have already covered about these questions and indications of sepsis, urosepsis, pancreatitis, burns, and ARDS. Most important, Rajiv, I would like you to be short and precise. We just have got a few minutes to go. How will you select your patients? What is the right patients to select ulinastatin? I would just have a quick opinion from you and also from the other panelists quickly.
I mean, since we have already established pancreatitis, any patients with pancreatitis with organ dysfunction or
No, I want the selection of exact criteria. What do you look for
Basically,
organ dysfunctions, or do you monitor any lab parameters for selection of this? Not the indication.
one of the parameters is septic shock. Hypotension definitely is an indication, and lactic acidosis is an indication where we could use it. Other than organ dysfunction, lactic acidosis and septic shock. I don't know whether we could use interleukin 6 as a marker in such conditions, though the data
It's
is
an
we don't.
inflammatory marker can be
Yeah,
considered. Does anyone
yeah,
use CRP, expert panelists?
Yeah, we
yeah.
we
Right.
regularly. I showed you the data.
Yes.
We use the highly specific CRP
Yeah.
and procalcitonin.
Procalcitonin, yeah.
We
So
can use those
definitely
markers as a guide to treatment. Yes.
Yeah, using CRP will be much more cheaper as compared to doing the IL-6 or even considering the procalcitonin levels here. So definitely we know that severe sepsis, organ dysfunction, early onset of organ dysfunction with lactic acid, definitely with increased inflammatory markers should be one of the indications. So we won't go into it. We have definitely seen the use of ulinastatin in pancreatitis. We have also seen that there are associated better outcomes, which were also seen in papers which were published, which Rajesh showed us, along with Dr. Dilip Karnat's paper. And even it was really an eye-opener that we definitely saw the use of ulinastatin in urosepsis, where definitely Dr. Nayak covered it up for using it in acute kidney injury, in patients of post-transplant, and even in patients, those who are there with a peritoneal dialysis as to it. So most importantly, we have seen that it is a very effective drug. We know that starting the treatment initially and the timing of the drug is very, very important. Most importantly, it reduces the inflammatory markers, and the dysregulated host response is then brought under control so as to have the organ dysfunctions which are really coming under control. So I would just like you, since we are running really out of time, we know that are there any out-of-the-box indications? This is one question, like burns or any other patients have you used out of the box? Quickly, I would just like to run through the panel, starting with Kapil. Yeah, do you use it in trauma patients since you have a neurotrauma unit?
No. I haven't used any out-of-the-box indications.
Okay. Dr. Nayak?
Yeah, my indications are all out of the box as of so it's basically all renal indications. None of them, and we are probably the pioneers. Peritoneal dialysis has been out of the box, and when there is a sepsis cascade happening, you have to burns. We don't treat burns. We it's not our specialty.
Okay, Rajesh, do you have any experience of the out-of-the-box indications apart from what we saw?
Dengue shock syndrome we have used quite a
Okay.
lot. Whenever
Okay.
we used to get very dengue shock syndrome and this fulminant course, it has used. Few patients, and I've not done directly, but few patients I have done as a consulting advice in Bonn also. Good result. And definitely some of the HLH syndrome due to unexplained reason. Some of the transplant patient, like recently we had a liver transplant patient gone into sepsis. We have used this. So out of box, we have where affordability is not issue, and we know the drug has got very safe profile. We have started advising this, but as a adjuvant therapy, not a definitive therapy.
Thank you, Rajesh. Quickly running
We have used for Steven Johnson's. We recently had a patient with Takayasu arthritis where we used. We have been using it for ARDS and COVID ARDS. We use a lot of patients, and probably we came out with the guidelines also. COVID, there was a protocol, Shanghai protocol, where the dosage was almost 16 to 20 lakh per day. So there was a report from Bhopal sometime back on jellyfish poisoning. There are wide varieties of.
We did publish that the timing of initiation is more important,
Absolutely,
especially for in COVID patients. So these are the things. Just one quick question: what is the duration of therapy you give it? 5 days, 7 days, or you stop it after 48 hours after resolution of shock? Or are there any guidelines you think of? Quickly, Yash, your opinion?
Generally, we take for 5 days, but depends if the patient is still in the phase of SARS and patient is not improving, could be 7 to 10 days also. At times, we have stopped within 2 to 3 days for cost issues and patient improved.
Okay, Rajesh,
for sepsis, 5 days, 5 to 7 days, but acute pancreatitis 10 days.
Okay. Dr. Nayak, your experience, your duration in renal failure patients or renal patients?
No dose adjustment, 2 lakhs twice daily for 5 days.
5 days. Kapil, your duration? Okay. So more importantly, there's a last question here. Can ulinastatin be used in pregnancy and lactating women? Quickly, Rajesh or Yash?
Yes, there's no contraindication. It doesn't have any. So far, there has been no report of the teratogenicity or effect on pregnancy. If patient is having sepsis or acute pancreatitis, same way it will be treated, and definitely they are more immunosuppressed. So we need to really look for the markers, because the pregnancy is a condition of immunosuppression. So we really need to look at that patient is in pro-inflammatory. So here you do a marker like IL-6 and CRP and PCT. If it is high, definitely you should use.
And of course, the special monitoring is not really required. You are really monitoring all septic patients regularly with your blood counts and PT-INR. So regular monitoring. So this is about it. So I would just like to end with a take-home message. Yes, ulinastatin is an excellent good ray of hope to reduce morbidity and mortality in sepsis. What we have seen from original research studies which were published in pancreatitis, in urology, sepsis also. Most importantly, you must see that you have to select the right patients for the right indications, and the initiation and the timing of initiation of ulinastatin is most important. And studies have shown that early initiation within the first 48 hours is the key of the success. It can be given without any complications, and use ulinastatin in the lyophilized form is much more better because it doesn't require any cold change of storage or no added preservatives. So this is in a short take-home message. We have seen about various indications, and I would really urge that it's an excellent molecule where it should be used at the right time in the right doses for the right patients in sepsis or other indications what you have studied and pancreatitis to reduce morbidity and mortality. I would like to thank all the panelists for taking this time out. I would also like to thank all the speakers for taking out time and giving an excellent presentation. And on behalf of all the participants here, I would also like to thank all the attendees for taking out time for almost 90 minutes and be a part of it. Unfortunately, because of the lack of time and not much questions into the chat box, and we have tried to cover up all the aspects, I'm not taking any extra questions. And I thank Poland and Sepsis Forum for arranging this excellent webinar. And I would say thank you, and we hope to see each other again in the future with a new topic for new discussions with a new ray of hope in sepsis. Thank you very much.
Thank you, everybody. Good night.
Thank you, Subhal. Thank you, everyone. Good night.
Good night.
Good night.
Thank you, sir.
Good night.
Thank you, Subhal.
Thank you.
Thank you, Nayak.
Thank you very much.